Alrighty, everyone. Welcome once again and good evening. I'd like to welcome you all to Let's Talk About Men and MS, the topic we have been waiting to do and share with you all. You all are in for a treat tonight. We have a very special guest, Dr. Paul Alphonse Jr. And let's give him a virtual round of applause in your seats because we have an amazing presentation in store for you all tonight. But before we do that, I have to tell you a little bit more about who we are. We're the Multiple Sclerosis Association of America, also known as MSAA. We are a leading resource for the entire MS community, improving lives today through vital services and support. Many of our services, like the helpline, our educational services, our online resources, and community connections. And please feel free to ask any questions of our national toll-free helpline that's located on your screen. And please don't forget to dial extension 154 for English. And if you would like to speak to a service provider in Spanish, please dial extension 131 and visit our website, mymsaa.org, and learn more today. Remember to stay connected with us. Yes, please make sure you all take out all of your phones. All of your phones are on your desk, they're in your hands, or just write down the number if you're watching this from your phone. And don't forget to get all the latest updates on all our next MSA webinars, educational events that may be coming to a city near you. And just to stay in the know with what's happening and the latest news in MS research, text MSAA to 75101. Remember, MSAA to 75101. Remember to share with your friends and follow us on all of our social media platforms that you can find. A few reminders for tonight's webinar. During tonight's program, please feel free to submit all of your questions using the Q&A feature in the bottom of your Zoom toolbar. Today's webinar is being recorded and will be available as an on-demand video in MSAA's video library within the next couple of weeks. And please, 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 don't forget to complete the brief survey for your feedback. It's extremely important because that survey helps us to plan for more topics in the future, bring back great presenters like our one tonight, and to let us know what you're interested in the latest news in MS and research. A couple disclaimers tonight. As a friendly reminder, this program is for informational and educational purposes only and does not constitute as formal recommendations. Although we have a fantastic physician here, if he is not your primary provider, this is for educational uses only. Please remember to check and speak with your actual healthcare team, your healthcare provider that you speak to on the normal daily basis about any concerns about your diagnosis, treatments, and maybe a few recommendations. Now tonight, viewers, please be advised, this presentation contains images of male anatomy and is recommended for adult viewers. The topics of this presentation will be real-life scenarios and candid. We invite the audience to share and ask questions at the end of the presentation. Now for a very special welcome and introduction, a man who I known for many years, who also is not big on bios, as you can see right here. He doesn't like to talk much about himself. He really likes to spend time talking to patients and sharing all the information, all the research. But Dr. Paul Alphonse Jr., who is a urology specialist located in the Roswell metro Atlanta area and has over 24 years of experience in the medical field. He has extensive experience in urinary conditions. So, my gentlemen out there, those that identify as male with male parts, please, please, please submit all of your questions. Ask anything that may be coming to mind, and we'll make sure that we can answer as many questions at the end, or perhaps you send them in and we can share with Dr. Alphonse later. But without further ado, I'm going to stop talking and give the floor to our esteemed guest, great friend, colleague, and brother, Dr. Paul Alphonse Jr. It's all you.
Thank you so much, Darian. Let me go ahead and share the screen. And please let me know when we are live. Does it look good?
Looks great to us.
All right, excellent. Good evening, everyone. This is a topic near and dear to me when we're talking about men and men's health. and talking about something that's very important in terms of um, erectile dysfunction and urinary continence, which are two very important things that occur very frequently in the multiple sclerosis population. So I'm going to delve into this, and trust me, when I had the conversation with the society in terms of what are some of the things that I could talk about, I mean, I had probably 10 different things that I could talk about, but I really wanted to whittle it down where it was at really bite-sized material. So I really made it as concise as possible. And towards the end, I'm sure there will be questions. Please feel free to submit all your questions towards the end, and then we can make sure that we go through them. All right, pressing forward. When we're talking about erectile dysfunction, what is erectile dysfunction? Erectile dysfunction is essentially the inability for an erection to be firm enough to perform the act of sexual intercourse from its inception all the way to its completion. And there's very many different stages of erectile dysfunction. We won't get into that, but essentially those are the important things. Now, when we start talking about what causes erectile dysfunction, there's a litany of things. Diabetes, common. Heart disease, common, from hypercholesterol, anemia, elevated cholesterol, those type of things. When patients have different types of surgeries, whether it's prostate cancer surgery, bladder cancer surgery, colon surgery, rectal surgery, these are surgeries that can damage some of the nerves. And when you damage some of the nerves that go to the penile area, it can cause erectile dysfunction. There are certain medications that as well can cause erectile dysfunction. Medications for high blood pressure, those are common things. Spinal cord injuries, if people are unfortunate enough to incur a motor vehicle accident and have a spinal cord injury, the level from the injury and below can be compromised, where erectile dysfunction is a common occurrence. And there's hormonal imbalances, such as low testosterone or elevated FSH or these other hormonal imbalances that can cause erectile dysfunction. And then, of course, there's neurological things, which we're going to delve into tonight, that is commonly seen in multiple sclerosis. So when we start talking about what are some of the problems that we see in men with MS? So MS, as we are very familiar, disrupts some of the nerve signals that starts all the way from the brain, travels through to the spinal cord, goes through all its many tributaries, getting to the penile area. And when it is unable to get to the penile area, then it can cause difficulties with erections. There's other things that MS can cause, such as fatigue and stress and depression and some of the pain. And these are all also other things that can contribute to erectile dysfunction. So we're going to delve into what are some of those things, and we're going to talk about how common erectile dysfunction is. When we start talking about erectile dysfunction, this is a common issue that can occur in men who are 40 years old and older. But when you start adding the things such as high blood pressure that can occur in your later ages, diabetes that can occur in your later ages, elevated cholesterol that can occur in the later ages, that by itself can cause significant issues with erectile dysfunction. But then when you add erectile dysfunction issues associated with multiple sclerosis, the numbers go up. And those numbers can be as high as 73, all the way to about 90% of patients who have MS can have some challenges with erectile dysfunction. So I say that not for people to get despair and just say, well, it was me, that's it, there's no other options for me. There are plenty of options. And we're going to go from the least invasive option to the most invasive option so that you know what's out there for you, because there are solutions. So going from the easiest, what are they? A lot of the oral pills, some of the oral pills that some of y'all may have in your pocket right now, but Things such as Viagra, Levitra, Cialis. All these medications are pills that are designed to be ingested, go through your circulation, and these medications filter and go directly to the artery in the penile area and cause those arteries to expand. When those arteries expand, that's what helps to rush the blood go into the penile area and help patients to get an erection. Now, these medications are not like not like taking a Tylenol or an Advil, where you take it and immediately you get an effect. These medications have to be taken anywhere between a half an hour to almost a full hour prior to anticipated intercourse, because that medication has to get into your stomach has to absorb it, it's absorbed into your bloodstream, and then the medication has to get inside the right area. So those medications do take time for them to work. So you have to plan accordingly. And these medications are not necessarily foolproof. There are certain medications that have certain restrictions, if you will. There are medications such as Viagra. You take that medication, and say, for instance, you have a high fatty meal, something maybe with high in calcium, milk products, or something like that. These are foods that are commonly can inhibit the absorption of that medication and prevent you from getting the onset that you're looking for. So it sounds counterintuitive. You take the medication, you go out for a great dinner, and maybe stop by and have some Cold Stone ice cream on the way home, and then let the rest happen up to your imagination. But when you have all that food and all those different types of food products, it can actually prevent the absorption of Viagra. Some of the other medications like tadalafil or Cialis or vardenafil, which is Levitra, those medications are not as food restrictive. So it sounds a little counterintuitive to really have an empty stomach for some of those medications, but some of those medications, that's how they work best. And they do have some of their side effects. There are side effects such as massive headache, and where some of these headaches are so severe where the headache in and of itself supersedes the benefit that you get from the erectile dysfunction medication. So when your headache is worse than the actual what the medication benefits give you, you can see how that can be a little upsetting. And then there's other things such as runny nose, flushing, gastric reflux, upset stomach. Those things are things that can occur. And they are not cheap. These are medication that can run anywhere between $20 to $30 per pill, but there's other ways out there, if you will, to make it a little bit cheaper, such as Cost Plus, GoodRx. So these are things for you to look at. So what else is out there? I'm glad you asked. There are other things such as vacuum erection devices. The vacuum erection devices is an external vacuum pump where you push the little device, if you will. And when you push this little battery operated device, it creates an artificial suction. That artificial suction creates the erection. And there is a little band, if you will. And that band goes at the base of the penis, holds the blood inside the penis. And when it holds the blood inside the penis, that's what causes the artificial erection. So, yes, this is something that doesn't require any medication. This is something that doesn't require any food restrictions, if you will. But it is something that does require manual dexterity. So for patients who may have arthritic problems, or if the MS may have progressed to the point where you don't have the manual dexterity to allow you to be able to push the button and to manipulate the ring, that may be something that may be a little challenging for you. And for some patients, it may be a little cumbersome. There are some limitations where you have to shave appropriately to make sure that you get a good suction. And so again, these are some limitations of the vacuum erection device. So what else is out there? Glad you asked. There are other things such as urethral suppositories. Urethral suppositories are medications that go directly inside the penile area. These are medications that are Excuse me. These are medications that are similar to the width of a rice pellet. And this medication is actually inserted into the tip of the penis. It dissolves in the penis. And when it dissolves, the medication seeps into the tissues of the penis, causing the artificial erection to occur. So for patients who either can't take the Viagra because it causes a massive headache, or if you're on other medications such as nitroglycerin because of a heart condition and you can't take Viagra, Cialis, or Levitra, this is a viable alternative where you can use this medication and you don't have those restrictions with those other pills. So it's fast, it's easy. When you put it in, it does take anywhere between 30 to 45 minutes for you to get the onset. And when you do get the onset, then you do get the engorgement of the penis that you are anticipating. It does have anywhere between a 65%, if you will, effectiveness. So not everyone who uses the medication will get the rigid erection that they're looking for. And for some patients, it is a little cumbersome trying to put the medication inside the tip of the penis. For some patients, that's a little squeamish, and that may be a little challenging for some patients to do. It is a medication that must be refrigerated. So it is something that has to have some travel considerations so that when you are traveling abroad, make sure that it's in a cooler or a uh, um, ice pack to make sure that the medication stays effective for use. In terms of disadvantages, we talked about that. The pain, a little uncomfortable using medication, and we talked about the refrigeration. So what else is out there? There are other things. There are injections, and these are injections exactly where you think they go, on the side of the penis. So very similar to how a diabetic will take medication and inject it directly into the penis. This is medication that is in, excuse me, well, a diabetic will inject medication such as insulin for their diabetes. This is similar, but where you would inject medications directly into the penis. So this is not insulin, but this is a liquid Viagra, for lack of better English, if you will. And this medication is called Trimix. It's tri because it's got three medications: propavin, phentolamine, and prostaglandin E1. Those three medications together are what we call vasodilators. They dilate the artery of the penis. And when they dilate the artery of the penis, they help to engorge and cause more blood to be able to get into the penis, giving the erection. So, in terms of effective, it is probably the hardest non-surgical option that is out there. Now, that being said, it does require a needle. It does require travel consideration. It has to be refrigerated. So these are things that need to be on dry ice when you are traveling. And so these are some considerations. Not to mention some of the obvious discomfort when you are on a learning curve using this medication. It does require injection into the penile area. Initially, that's very uncomfortable, but after you've done it quite a few times, it becomes a little acquired, if you will, and patients get a little bit used to it. But there are some scarring that can occur, and so these are things that they should keep in consideration. The biggest downside to the penile injection is there has to be a specific sweet spot, if you will, in terms of how much of the medication is used. So anywhere between 0.1 cc, 0.2, 0.3, all the way up to a full cc of the medication that is used. So when you come into the office, we do a trial in the office. I inject you in the office. Patients themselves can see the results. Then we have the patient come back where we do what is called a patient teaching, where we actually have the patient duplicate the exact same maneuver, drawing up the medication, injecting the penile area. We teach you exactly where to inject, where not to inject, and we need for you to know exactly how much of the medication to inject. Using the right amount and getting the result you're looking for is great. What we don't want you to do is where you say, well, if a little bit is good, then more must be better. Incorrect. That's where patients can get into what we call priapism. Priapism is a big fancy word where the penis essentially gets stuck in the on position. And when it gets stuck in the on position, that's when the penis stays erect. And we have to meet the patient in the emergency room to withdraw the penis, withdraw the blood out of the penis, which is quite painful, as you can imagine. So that's something that we are very, very important to make sure we teach the patient. Use the right amount, no more, no less. You use the right amount to get the result you're looking for. Not enough, you won't get the result. Too much, we're meeting in the emergency room. So now that I've completely scared you away, what are some surgical options when all those things fail? The pills, the urethral suppository, the penile injection, the vacuum erection device. What else is out there? So there is what we call the penile pump. The penile pump is an artificial device that is implanted into the penis. And this is a surgical procedure where we implant a device into the penis, we implant a device into the scrotum, and we also implant a device above the bladder. And that three-part connection, if you will, duplicates the artificial erection. It is made out of polypropylene. And so this is a synthetic, if you will, type of device. That synthetic device has saline solution or salt water in it. And that saline solution is something that is placed at the time of surgery. You don't have to go to the gas station and get it refilled, if you will. And this isn't anything where you can use normal wear and tear and get a flat tire, if you will. So they have a shelf life, just like any man-made material does, which is anywhere between 15 and 20 years. And after 15 to 20 of regular, normal use, then yes, it would probably need to be exchanged. And when it's exchanged, it's a simple procedure, back to the operating room, out with the old, in with the new. It's a procedure that takes approximately an hour, hour and a half to do. So it is a procedure that does require all the appropriate standard precautions for any type of surgery. We need to make sure your heart's strong enough, lungs strong enough, that you don't have any other cofactors that would prevent you from having surgery. So when we look at what are some of the advantages and disadvantages, obviously it gives you a rigid erection, strong enough for penetration. But the benefit of this is that the erection will last as long as you want it to. You want to stay up for 1 hour, it stays up for an hour. You want to stay up for 6 hours, it stays up for 6 hours. You want it to stay up for 6 days, it can stay up for 6 days. I don't know how many people are at this for 6 days, but just in case if you are one of them, then this is for you. But for sure, this is something that truly is not your first option. This is reserved as your last option. When everything else fails, then this is what is reserved for you. It does require, again, appropriate manual dexterity for you to be able to push the pump and make sure that you get the amount of girth and erection that you're looking for. So this is a viable alternative for the inflatable penile prosthesis. There are pluses and there are minuses associated with that. So for the sake of time, I'm going to transition directly into part 2, which is talking about urinary incontinence. What is urinary incontinence, you say? Essentially, when you can't control your urine. So not to make a lot of the situation, but urinary incontinence can be a very debilitating scenario where you are unable to keep the urine to keep yourself dry. So how does that occur? Well, your bladder is an apparatus that holds the urine. Your prostate is below. And then your sphincter is a muscle that sits beneath the prostate, and it wraps around the urine channel. That urine channel is called the urethra. And that urine channel, if you will, that muscle will squeeze and close the urethra and prevent you from leaking. Now, there are a number of different scenarios where we won't go into, but there are different scenarios where that urethra sphincter doesn't work the way it's supposed to. And when that sphincter doesn't close the way it's supposed to, you can leak. And so what are some of the leakage issues you can get? Stress incontinence, where if you lift situation, exercising, sneezing, coughing, then you can leak. And that's from basically a weak muscle. Or you can have issues with urge incontinence. And urge incontinence has nothing to do with the sphincter, but it's from your bladder. And when your bladder is unstable, so basically when you get the sensation that you got to go, you got to go. And if you don't go immediately, you will leak on yourself. And then there's a combination of the two called mixed incontinence. So what are some scenarios that can cause these leakage issues? Prostate surgeries again, traumas such as pelvic surgeries, spinal cord injuries, spinal diseases, and neurologic diseases such as diabetes and MS. These can cause some of these incontinence issues. How do you fix it? Well, let's talk about it. From least invasive to most invasive. Starting from the least invasive, there are pills. There are a gazillion pills that are out there. But essentially, you can put them in two camps. The ones over here on the left are what we call your anti-muscarinics. These work a particular kind of way to block certain receptors in your bladders called the muscarinic receptors. And they're very common: ditropan, detrol, Vesicare, Toviaz, Sanctura. These are very, very common. They've been out since the early 1990s, and there are newer ones that are coming out all the time. But they do cause some common side effects. And some of these common side effects can be dry mouth, some blurry vision. They can cause some cotton mouth. They can also cause some sweating issues and some constipation. And the reason being is because the muscarinic receptors are in the bladder, and they're in other places such as the colon. So hence the reason for the constipation. And they're in your saliva. And so hence the reason for the cotton mouth, and for the blurry vision that are in your eyes. So hence the reason for the blurry vision. So these pills don't know that they're only supposed to work in the bladder. They will work in other parts of your body as well, giving you some of these side effects. So there's another group of medications called a beta-3 agonist. And these are things such as pills such as Myobetrix and Genteza. These were newer, if you will, generations of medications to try to counteract some of these negative side effects that the muscarinic receptors can cause. And these do cause some great benefits in terms of calming down the bladder. But again, they do have some side effects where when they block the beta-3 agonist receptors, they can cause some elevation of your blood pressure. So if you are somebody who is on multiple blood pressure medication and you take this pill as well, it can make your blood pressure numbers rise by anywhere between 5 to 10 points higher. And that for some patients, that can be a big deal if you have very brittle high blood pressure. And there's other things that I'm not going to go into, but there's Botox you can inject into the bladder. There's pelvic floor muscle exercises, Kegel exercises, bladder training. So there's other things that are out there as well. So what other options are out there besides the pills? You see, there's diapers. Diapers and these pads. These are some of the quick, easy fix, if you will. Put them on. Hopefully they keep you dry. Downside is these things can get very expensive. And rough numbers, if you will, where if you use only 2 pads per day, it can run anywhere between $620 a year. If you up to 4 times a day, looking at $1,200. Now, if you're 7, 8 times a year, you can well get into $2,500 per year. So yes, they can add up very, very quickly. And then there's other devices. such as catheters. These catheters go inside the penile area, and they are a great short-term solution in terms of helping to divert the urine, but they can cause some long-term problems because infection, bacteria can crawl inside those catheters, get inside the bladder, and they can cause urinary tract infection. So going else, what else is out there? There are some bulking agents. So these bulking agents, very similar to fillers, if you will, that you see certain people put in the lips area. These are some collagen or carbon beads that can go directly into that sphincter, that muscle that we talked about earlier. And when you put some of these bulking agents into that area, it can puff up, if you will, for lack of better English, the sphincter muscle and help that sphincter to do its job just a little bit better. It's not super effective, but for the patients that it does work for mild incontinence, not very severe incontinence, but mild incontinence, it will actually do the job. So going again in this trend from least invasive, we talked about pills, we talked about diapers, we talked about catheters, talked about bulking agents. So now we're going to look at some surgical options. What are some surgical options? There's two big categories. One of them, slings, and these are slings that can be used very similar, that slings are used for women to close off the urinary channel. And we can also use a artificial urinary sphincter. And I'm going to show you examples of both. So the sling will help to restore some of that closure, if you will, the urethra to help minimize a lot of that leakage. And well, I can tell you about it or I can show you. Let me show you how it works. So this right here is the sphincter. And so there are some anchors that are put into the bone, 3 on each side. Once we put those anchors in, then we have these sutures that are replaced. And then we put this mesh graft, and the mesh graft is attached to the sutures, and it will cinch everything in place. And this again is a side view, so you can see how it works. And it helps to buttress or helps to close off that area to minimize a lot of the leakage issue. And this is what it looks like when you look inside the urinary camera. So this is called a cystoscope. So I'm going inside the urine and through the penile area, looking directly inside that sphincter area, and that area looks relatively closed. So that's exactly the way you want it to look, and that helps to minimize a lot of the leakage associated with urinary incontinence. So what are some other options? Other surgical options are artificial urinary sphincter. An artificial urinary sphincter is a man-made way of trying to duplicate what God created. It's an artificial device, and that artificial device will wrap around the urethra, and you push a button to make fluid from the reservoir go down to the hand device into the urethral sphincter, and then it has an automatic timer. So after approximately 15 to 20 seconds, it will automatically fill back up again. So it is not perfect, but it is the closest thing that we have to the male sphincter. So if all the conservative therapies, such as the medications, the diapers, the catheters, the sling, if those things didn't work, you can use the artificial sphincter as well. And this is just going to give you a little side view. This is the reservoir. This is the cuff. This is what goes inside the scrotum. And let me just show you how it works. So the reservoir above the bladder, the cuff is around the urinary channel, and the pump is in the scrotum. When it comes time to urinate, you push the pump, it moves fluid from the reservoir, opens up the cuff, allows urine to leave. It's got an automatic timing device. So it will automatically close off on its own and reverse all the fluid. And then the urine fills back up again. If you feel like you have more urine that you need to let go, or how, as we say in the urology world, if you need to pee again, you can push the device again and you can urinate again. So we went over a litany of information and quick bullet points talking about erectile dysfunction, talking about urinary incontinence, talking about the minimally invasive all the way to the most invasive on both of those talking areas. These are things that truly have to be tailored to the patient. The same way how everyone can't wear the same type dress or the same type suit, you have to find a treatment that is tailored specifically for you. So if you have an issue, you have a problem, talk to your primary care physician. Your primary care physician will refer you to a urologist so that you can find the tailored therapy for you. And then that way we can make sure that we find the therapy that suits you best. So this is the time for question and answers, and just want to make sure that we open up the floor. And that's the presentation.
Thank you so much, Dr. Alphonse. And can we just give Dr. Alphonse another virtual hand clap? I know you all, we can't see you, can't hear you, but we just like to thank you for this amazing, informative presentation. Just so much information you've shared. And we, of course, have quite a few questions that have been coming in. So let's just go ahead and jump to it. You left quite a bit of time, so everybody get more questions in. How can TRT affect MS outcomes?
So TRT, my presumption is we're talking about testosterone replacement therapy. So that goes back to the conversation that I talked about when we first started. I had so much to talk about. TRT in and of itself is another beast in its own, and that would be easily a 2-hour presentation in and of itself. But testosterone replacement therapy in and of itself is truly designed for patients who are deficient in testosterone. So it is important to get your levels checked. And when you get your levels checked, it is important for your primary care physician to make sure that they are drawn at the appropriate time, because testosterone has its peak from 4 a.m. in the morning till 8 a.m. in the morning. So if you show up at 4 in the afternoon or 2 in the afternoon to your doctor's office talking about, hey, can you check my testosterone level? And they draw your testosterone level, you're going to get false values. So it's very important to make sure that those values are drawn first thing in the morning so that we can appropriately see exactly what those levels are. And if they're deficient, we can treat.
Wow. Talking about learning something new every day. I didn't know that your testosterone levels were high at a certain period of day, but I guess that makes sense, right? I mean, everything has a period of time that it's just high. That's just quite interesting to hear. So I have a couple more questions here that I definitely want to ask you. So now back to erectile dysfunction. So what if you're able to get an erection, but experience a loss of sensation during penetration, which also may prevent someone from ejaculating? Are there any like recommendations, plan of actions for that situation?
Right. So sensory deficits are common issues that can occur in patients with MS as well as with diabetes. Where we are in this day and time is able to fix, if you will, the erection issues. The sensory deficits associated with these neurological problems, if you will, for lack of better English, reconnecting the wires, we're not there yet.
Hmm.
So we don't have a surgery to reconnect the sensation. There isn't a medication to reestablish, if you will, sensory deficits that have been lost. So we are not there yet, but we hope with more research and that we can make some headway in that area.
Absolutely. That would be awesome. Always here for research here and promoting research of any time. So here's a question. So although go back to our disclaimers, um, please check with your professional. But I'm going to ask you this question, regardless, someone who's both on mirror, oh my goodness, hopefully I say the medicine right.
And metrics.
Yes, goodness, it's the end of the evening, it's end of the day, so words are getting me. Entropysium chloride, if I said it right. Is that normal? And will they work? Does one work better than the other? Do they work better together? A little bit about that.
So, yeah, so that's where the disclaimer in terms of making sure you are in sync with your urologist. Basically, what the person is asking is, can you mix and match medications, if you will, to get the desired effect you're looking
Mhm.
for? I'm a true believer in using the most minimal amount of medication to get the maximum desire you're looking for. So, Tropium or Sanctura or Mybectrix, both of those medications are different classes of medicine. One's an anticholinergic, the other one's a beta 3. So these are medications that can work on different parts of the bladder. But again, these are things that I would try as a urologist to maximize one medication first. And if I maximize that medication and I'm not getting any relief, then you can try an anticholinergic, but then you do run the risk of getting what we call polypharmacy, where you keep adding ingredients, if you will, into the stew, and then eventually things are not tasting the way you want it to. That's a poor analogy, but that's the best thing that could come up with.
No, analogies are always great. It helps me as someone not as brilliant and as, as familiar with some of this, understand things better. And I'm sure everyone else can appreciate a great analogy as well. As we talk about, um, urinary incontinence, there's a couple of other questions around there as well. Your last incontinence option, would you consider that the gold standard? The ART pump covered by isn't, and I guess is it covered by Medicare? I'm not sure if you know that, if I'm
Yeah. So
understanding that
artificial
correctly.
urinary sphincter. Artificial urinary sphincter is the gold surgical standard. It's the one that everything else is compared to in terms of slings, the injection therapy, coaptide collagen, so on and so forth. But it's also, again, goes back to the conversation in terms of you don't always want to use a square peg to fit every round hole. You
Mhm.
need to find the right surgical procedure for the right patient. If you have mild incontinence, there are certain procedures that are good for you. Moderate amount of incontinence, then there are others. Severe amount of incontinence, then that's when you would use something like a artificial urinary sphincter. So you really have to look and see exactly how severe the problem is, how many pads you're using per day, how many times you're leaking on yourself. Those are different things that help us to grade the severity and let us know what works best for you.
It's very good. Every patient is different. So, still around the bladder, are you familiar with any really good pelvic exercises that can help control bladder?
Sure. So that's again a nuanced question. And the reason I say that is because every person's reason for incontinence is different. Is it a overactive bladder? Is it a weak sphincter? Is it a combination of the two? So pelvic floor muscular exercises are truly reserved for people who have a weak sphincter, and you're exercising a muscle to try to make that muscle stronger so that you don't leak. But there are tests that need to be done to help us to prove if that is your issue. And that test is called a urodynamic test. And that urodynamic test lets us know if it's a bladder problem or a sphincter problem. And depending on which of the two it is, then we can talk about different algorithms from there.
Absolutely. Thank you. I know we talked a little bit about this is before we got on the webinar about how large a presentation would be, what all should we cover? And of course, we got some more questions about prostate cancer. So, what are the question is prostate cancer common? and it's are more prevalent as a comorbidity in men that are living with MS. I'm not sure, if you have research or anything around that, but yeah, I feel
Got
like
it.
sharing.
So to help prevent people from not going home at 11 o'clock at night, doing a lecture on prostate cancer, as well as TRT, as well as erectile dysfunction and urinary incontinence, I had to truncate this discussion. But prostate cancer in and of itself does have some risk factors. And some of those risk factors tend to be familial, meaning that if you have a primary degree relative, a father, an uncle, a grandfather on your paternal side, those are things that put you at a risk for having prostate cancer more so than someone who does not. And there's other risk factors such as your ethnicity. We do know that African Americans have a higher propensity of prostate cancer than their Caucasian counterparts. So, for those reasons, people who are in certain risk factors do require a different screening protocol.
Mhm.
Whereas if you're low risk, you can start screening at age 50. But if you're high risk, then age 40 or even sometimes at age 35, they're getting screened for prostate cancer if you happen to hit every single one of those risk factors. And so that would be the issue with that. Now, MS and prostate cancer, there's no correlation that we are aware of whatsoever.
Well, that's really good to know. Kind of, well, taking us back to, the topic of ED or erectile dysfunction, another question that came in, um, if erections are lost prematurely, is that a sign of erectile dysfunction as well? You talked a little bit about the signs, but if there are any other additional signs or things that we should be aware of to be looking out for.
Got it. So if I understood the question correctly, premature ejaculation?
Correct.
Okay. So premature ejaculation is kind of a subset, if you will, of erectile dysfunction. Yes, it does prevent you from completing the entire act of intercourse. It is a type of erectile dysfunction. Now, the way that premature ejaculation can be treated, there's a number of different ways. Some of them are behavioral techniques where we can use biofeedback to teach a patient to mentally allow themselves to last longer by helping to do what is called sensory desensitization, where you can teach yourself if to not get overly excited too soon. There are creams that you can use to put on the penile area to help numb the area so that you don't get overly excited. But there's minuses with that because if you numb yourself, then obviously you can numb your partner and then no one feels anything. And then there are artificial things that you can use, such as injection therapy that gives you a rigid erection, but it also does require you to inject medication into the penis.
Mhm.
So, yes, there are things that can be used for premature ejaculation. It's about finding the right method that's best suited for you.
So thank you. Oh, and I just got a correction. It was if erections are lost prematurely to erections as a sign of ED. Um,
If erections are lost prematurely, say it
correct.
one more time.
Yes, if erections are lost prematurely, would that be a sign of erectile dysfunction?
It's a type of erectile dysfunction. Yes,
Got it.
it
Perfect.
is
Just
a
want to
type
make
of erectile.
sure I got this question correct. And while we're talking on that subject, is there an age limit that you would say to stop considering, wanting to get testosterone therapy or any other type of your recommended therapies for ED erectile dysfunction and just being able
Yeah.
to still perform?
So testosterone therapy, very, very, very common conversation that happened. But testosterone therapy, I tell people, is the male equivalent of female menopause.
Hmm.
And so uh, when the body gets a little bit older, past 40 years of age, it's not unusual for a subset of patient to start producing less testosterone over time. And in producing less testosterone over time, it can cause issues with low sexual drive, low libido. It can cause erectile dysfunction, but it is very rare to see just testosterone as the sole cause of erectile dysfunction.
Mm.
Usually there's something else going on, meaning high blood pressure, diabetes. They're on other medications, antipsychotics, antidepressants. There's something else that's going on as well. So it's important for you to get a complete, full examination so that we can find out what all your risk factors are and make sure we treat them. Because if you have undiagnosed diabetes, we can give you testosterone till the cows come home. Ain't nothing gonna work.
Mm.
So we got to make sure that we treat the root cause as well as the adjacent issues as well.
Absolutely. That's good to know. We got a few questions around Botox. Do you have any opinions on Botox, especially if they're talking about for UI?
Yes. So Botox for urinary incontinence is, I tell patients it is specifically designed for patients who have an overactive bladder. So again, the same way how you use collagen to inject into the sphincter, this is medication that's injected into the bladder. So if you think about your bladder being really spastic, if you will, so imagine a medication that can calm the bladder so that it doesn't spaz so much. So that's what that Botox is used for.
Mm.
It does have its pluses, has its minuses. The very first time we inject your bladder, when your bladder is naive to the medication, we have to really gauge how much of the medication for it to use. Because too little, you see no results. Too much of the medication,
Mhm.
your bladder is paralyzed. And we can't just go in there a couple days later and suck some of the Botox out. Your bladder is paralyzed until the medication wears off. And that can wear off in 3 months and 4 months. So the very first time, I tend to undershoot on purpose to see exactly where you are and then to slowly titrate. Last thing that we want to do is get you to a situation where you can't pee at all because we put too much of the medication in.
Great point. We actually got another question specifically around overactive bladder. Part of it's kind of a few questions in this long question, but I guess one is is it common around a certain age? Do you start seeing, an overactive bladder at your early late 30s, late 40s, 50s? Like what's I guess is it common around
Got
a
it.
certain age range?
So in the non-MS population, overactive bladder tends to be more common in your 50s and 60s, more common in women. But in the MS population, it can be seen in a 30-year-old with MS because of the neurological issues that occur with MS. So that's where getting that urodynamic study, which is that I tell people it's just like an EKG. The same way the EKG tells you how your heart muscle is working, this is like the EKG of the bladder. It tells us how your bladder and your sphincter is working so we can know which is a problem. Is it the chicken or the egg?
Right, right. And within an overactive bladder, being able to use nocturia, um, still not addressing some of those needs. What are some other recommendations? Once again, this is back to our disclaimer, but what are maybe some other recommendations, some other options? And if there's also anything, that I also want to address, what we got questions about holistic treatments for anything, because
Yeah.
we're in the age of holistic.
So nocturia is basically getting up to use the bathroom a whole bunch of times at night.
Mhm.
And that's where that it's super important making sure that you speak with your urologist so they can draw the appropriate hormones. Something called ADH. You want to make sure that your antidiuretic hormone is normal. If your antidiuretic ADH levels are off, then there are certain medications that they can put you on to help treat that. Those medications do have their pluses and minuses, where your sodium level can either be too high or too low. So then you got to check your sodium. So getting on medication for nighttime urination frequency has to be truly diagnosed, truly monitored, and you want to make sure that it's not something else going on, like you don't have high blood pressure and you're taking your water pill at night. And so the reason why you're going to the bathroom so frequently is because your water pill is making you go to the bathroom at night. So you really, again, don't try to treat yourself according to Dr. Google. Really speak with your urologist so that the urologist can know exactly what's going on and make sure that they make the right diagnosis and the right treatment.
Awesome. Thank you so much. This really just goes back to, some other things that we even talked about earlier, making sure you can, contacting and conferencing with your healthcare team. It's more than just your primary care. Sometimes it does include your neurologist and your urologist and maybe a social worker, nurse practitioner. This really goes back to really making sure you have a strong healthcare team to support you and asking all those right questions. And thank you for teaching me a new word. It's nocturia, because I was trying to read the question. I was like, wait a minute. Oh, so that's an overactive blood. Okay, you gotta a couple times you gotta give me a couple words in between
There
to
you
get
go.
there. I was almost there.
You were almost there.
But I thank you. I definitely one last thing before we get out of here, especially as we talk to you talked about ED, some other questions just were coming in about holistic treatments. Are there things that folks can do, that when people are on or taking so many drugs already, that's the last thing they want to do is think about another treatment. There's just other things naturally that folks may be able to do.
Yes. And so, yes, there are a lot of anecdotal things that are out there. I always stress patients to make sure that they understand that when you are putting things into your mouth, that is man-made. Whether you get it from Walgreens or you get it from Whole Food, it is still man-made and it does have its pluses and its minuses. So I always want to make sure patients understand that holistic treatments, again, is man-made treatment. Just because there's not a prescription that goes with it doesn't mean that it's all good and no bad. So these are things that you really have to do your research. I'll be candid with you. I am not a holistic physician. I'm an allopathic physician. So the things that I talk about, the things that I was taught, the things that I show to my patients are allopathic regimens. And so that's my strong suit. But definitely there are holistic physicians that are out there, naturopaths that are out there. So if you are interested in looking at some of those treatment options, definitely reach out to a naturopath who may be able to help you.
Thank you so much. And before we go, any last words for our gentlemen that are here that are living with MS that may have trouble wanting to talk to not only their providers, their care providers, but it's also their partners as well about some of these issues. What's one thing that you would just leave with us today?
Yeah, the biggest thing is making sure that you understand that you do have options. Do not live in silence. Do not live in fear. Talk to your physician. Some physicians, just to be very upfront and honest with you, they themselves, as primary care physicians, are not comfortable talking about sex. So if you don't bring it up, they won't bring it up. This is something that is important to you, important to your spouse, important to your loved one. So you make it a point of talking to your primary care physician saying, hey, can you help me with this? And if you can't, can you send me to a person that can help with those things?
Well, with that, I don't know what else we could say to wrap that up. I want to thank Dr. Alphonse. Please thank you so much for coming and presenting today on some much needed talked about topics, some things that we like to keep in the shadows, but definitely should be brought to the front. Um, a simple reminder to everyone, please don't forget to take our survey. Please, please, please. That helps us continue to do great work like this, to have more programs, and to share widely with everyone. And don't forget to stay connected with us on all of our social media platforms and our text platforms. Until then, till next time, I want you all to have a great evening, and we look forward to partnering with you all and seeing you all again soon. Thank you, and have a good night, everyone.